You're muted. You can start.
Okay, all right. I think let's get started. Those that join will join us later. So good afternoon, everybody who's joined. Thank you for joining us. As you know, GECO, these meetings are specifically for the fellows for teaching, and they're hosted by the Gastro Foundation in association with Project ECHO. And these meetings take place every fortnight on a Monday at 6 p.m. And it is a platform for fellows to present, facilitated by the consultants and head of divisions. Today, we're going to talk about an approach to dysphagia, which is a massive topic. But what we've done is that we've asked Dr. Aslam Parker, who's a fellow at Tygerberg Hospital, to do a brief overview of the topic and not specifically getting into any specific diseases. And then Dr. Botha, who truly is an expert on the continent on esophageal disorders, is going to facilitate the session. And what she opted to do is that she's got 4 cases, and she's going to quiz Dr. Parker on the cases to make a few points. And then if we have enough time, we'll get to a 5th case where she'll try and summarize the session. So I think we are in for quite a lot, but a lot of learning and really a fun session. And if you think that Aslam is getting away with murder with a short presentation, as I said, he is the one that's going to be answering Dr. Botha's questions for most of the session. So Aslam, over to you. Please share the screen and you can please get started.
Is the screen visible to everyone?
Yeah, it's coming.
Okay.
Yeah,
okay.
I can see it.
Okay, good evening, everyone. Thanks, Prof. Mashiko, for the introduction. I'm from Tygerberg Hospital, Stellenbosch University. Thank you so much, Sassa, for assisting with this talk and the rest of the department. So just the definition of dysphagia. It can be defined as difficulty or discomfort in swallowing as a symptom of a disease. And then it can be divided into oropharyngeal and esophageal dysphagia. The anatomy of swallowing is essentially divided into 3 phases: an oral preparation phase, a pharyngeal swallow, and an esophageal transit phase. Each phase involves coordinated muscle movements and neural control. Oropharyngeal dysphagia, what's important is the history. Symptom onset usually within seconds after a meal. There may be accompanied drooling, coughing, nasal regurgitation, aspiration, or choking. It's very important to differentiate between oropharyngeal and esophageal dysphagia. Patients with the oropharyngeal dysphagia should be referred to an ENT surgeon and should have a video fluoroscopy in the presence of a speech therapist. A very easy test one can do at the bedside is to ask the patient to drink some water, and immediately the symptoms become evident. Esophageal dysphagia, on the other hand, patients often present with a history of, "Doctor, I have food stuck in my throat or my chest after swallowing." Symptoms may be specific to solids or liquids or both. And the symptoms often provide a clue to the underlying diagnosis here. So there are red flag symptoms and signs that one should always try and elucidate. One would be a very short history, progressive symptoms, age over 50 years old, persistent coughing or choking, the presence of aspiration pneumonia, significant weight loss. These red flags are essential to exclude pseudoachalasia as well. Common causes for that may be paraneoplastic syndromes, for example, small cell lung cancer. And then from extrinsic processes such as a prior tight fund duplication or laparoscopic adjustable gastric banding or tumors that are infiltrating the OGJ causing obstruction. So broadly, dysphagia can be divided into mechanical obstruction and motility disorders in terms of etiology. Mechanical obstruction would include your rings, your webs, your strictures, carcinoma, and then importantly EOE as well. And then your motility disorders would include your achalasia, ineffective esophageal motility, esophageal spasm, and systemic sclerosis. In terms of diagnostic tools, we have endoscopy, barium swallow, high-resolution manometry, and then one maybe to just add on here is also esophageal biopsies. So I've got a couple of examples. So this is an example of a patient with achalasia. In A, one can see functional stenosis of the esophageal junction. And then in B, one can see wrapping around the esophageal junction when doing retroflexion with the scope. In C, there is abnormal contractions which are visible of the body of the esophagus. In D, there's mucosal thickening and a whitish change. And then in E, you've got this dilated esophagus. And in F, you can actually see the retained saliva and food remnants. The scope is very useful. It helps exclude a lot of the mechanical obstruction causes. Also can show you complications of GORD and help do your biopsies for EOE. Over here, I've got two examples of a barium meal. Barium also useful to exclude cancers, GORD, Schatzki rings. So on the image on the left, you have a patient with achalasia showing a dilated esophagus with a tight lower esophageal sphincter, often referred to as a bird's beak appearance. And then on the right, there is a corkscrew appearance, which is common to spasm. The high-resolution manometry, diagnostically, your pathology can be divided into disorders of OGJ outflow, which would include your achalasia types 1 to 3, and OGJ outflow obstruction, and then disorders of peristalsis, which would be absent contractility, distal esophageal spasm, hypochondral esophagus, and ineffective esophageal motility. That is the end of my brief talk to Sassa's talk.
Okay, thank you, Aslam. I think that's what we wanted, because Sassa is then going to go into specific cases, which I think will be more useful and demonstrative than a lecture on the different conditions, of dysphagia. So I think that was the perfect setting. And we're now going to ask Sassa to please share her screen and then just start with the questions. Sassa?
Okay.
So Dr. Botha needs absolutely no introduction. If you have never met Dr. Botha, then perhaps you are really very new to gastroenterology. She truly is the only expert that I'm aware of in South Africa, if not the continent, on motility disorders and the tools that are used for the diagnosis and management of these conditions. So I think you guys are really, really very fortunate. We all are fortunate to benefit from her insights and her experience. Sassa, take it away. I'm looking forward to this.
Okay, thank you, Mish. Thank you for your very kind words. I sometimes wonder, I think you think I know more than I know. But I really love what I do, and I hope my enthusiasm can be handed over to somebody else to take over when I end my work session in the Feb. Okay, so I just also added a sort of an algorithm that one can use, but I think Aslam has covered most of it. And I think it's just important, I just want to emphasize again that we get so many referrals. People just talk about dysphagia. The referrals we get are so often oropharyngeal dysphagia, and that you should actually be able to make absolutely on your history. So I think what I find with a new generation of doctors, they don't spend enough time to listen to their patient. So I think it's just important that you must really make a difference between these two, oropharyngeal and esophageal dysphagia, because they really take two different routes, as Aslam said. Again, I just want to emphasize that we use the Chicago 4, version 4, protocol, and also to get to an algorithm to make a diagnosis of a motility disorder. When you look at, this is another way, if you just want to look at dysphagia or non-cardiac chest pain, the most important thing that you've always got to think is you've got to look at your IRP, your relaxation of your lower esophageal sphincter, so that you can immediately group it in the group of abnormal IRP versus the normal IRP, and then they are peristaltic disorders, whereas the abnormal IRP are part of the OGJ disorders. Okay, so I've decided to go a slight different route to actually divide my problem or my cases into patients with proximal dysphagia, mid-esophageal, and distal dysphagia. So I just want to try and move this thing a little bit away that I can see. There we go. There we go. Okay, so the first patient, the patient, sort of pointed very much to the upper part of the esophagus when she described that she had difficulty in swallowing. So what do you think this could be?
It could be a stricture, could be a web. It's very proximal.
But if you look where the little arrow is, there and there, it's a very typical little picture. And here, this is the pharyngeal pressurization of high resolution manometry. You can see here's the upper sphincter, and there's there's a pressurization here. So it's not the web or stenosis. It's something. I don't know how often we have seen it. Probably not as often as other problems.
A bar.
That's
Yeah.
right. Yes.
Cricopharyngeal bar.
Yes. So, oops. Now mine doesn't want to go on. Yes. So that's the cricopharyngeal bar that we see. And what is it also called? They like calling it something else.
I'm not sure.
Cricopharyngeal achalasia. That's you hear that term as well. And you actually did mention it. What symptoms do the patients also complain of?
So symptom onset very abruptly after eating, so regurgitation, nasal complaints, coughing.
Yes. So the big thing is, if, as you said, if you give them fluids to drink, they will cough, choke, and splutter. So that is typically what you find with the cricopharyngeal bar. Oh, I don't know why this thing doesn't want to. Okay. Okay. So yeah. So it's cricopharyngeal achalasia. You'll read about that in some of the journals. Okay. This is also proximal dysphagia. So what would that be?
Is that a diverticulum there on the top?
Yes, that's right. So what kind of diverticulum do you think that is?
I think it's probably a Zenkus.
That's right. And what are the symptoms associated with these patients?
All the dysphagia, and then food coming out of the diverticulum back into the throat afterwards. Hours later.
What's typical of it is regurgitation of food, but typical what about that food that gets regurgitated?
It's undigested.
Yes, and it's not acidic. Okay.
Yeah.
So it's your Zenkus diverticulum and regurgitation of undigested food. Okay, so the first case I want to present to you is a young Caucasian male that presented with intermittent dysphagia. What should you be asking this patient as well?
So for this patient, he's young, he's male. I'd like to find out, first I'd like to decide whether he's got esophageal or oropharyngeal dysphagia from the history. And then also I'd like to ask him about allergies. He's young. Does he have any good symptoms? Is it progressive? Rule out sort of red flags as well. But I'm not thinking about that as a cause as much because he's a young male. So
Yes.
I'd go down that sort of route.
Okay, but there's one specific kind of, I'll give you the nickname just now, but what you should ask about when he says he's had intermittent dysphagia, what should you ask him about this
Food bolus impaction.
That's right. And did it take him to the ER? Okay, that's
Okay.
quite important. They call it the steakhouse syndrome because usually the piece of steak gets stuck when they're eating their steak in the steakhouse. Okay. So it's very important to see if he's got bolus obstruction, and then you go into the allergies, the food allergies, because it usually can be associated with other allergic conditions. So what condition are you thinking of?
So I'm thinking of eosinophilic esophagitis.
Yes, yes. And what would your next procedure be?
So my next procedure would be gastroscopy. And then specifically looking at the mucosa, but also taking biopsies from the distal and mid esophagus.
Okay, so EOE, and you'll do a upper endoscopy. Okay, so now this is what you see. So what are you seeing if it's EOE?
If it's EOE, you are seeing furrows, you are seeing rings, you're seeing these sort of white plaques as well. And there may be edematous, or it may be normal also.
Yes, and the plaques can mimic, can look a lot like candida, you know, so you've just got to be aware and look for these things. Okay, so if the findings were totally normal, what should you do?
Biopsy.
That's right. Okay, so where and how many?
So you want a biopsy from the distal esophagus, and then also mid esophagus. You take about 4 to 6 from each section, depending on patient tolerance as well.
Yes. So it's interesting. I couldn't really come across, some say distal, mid and proximal. Other people say just distal and mid. I came across this one that sort of looked quite nice to me to remember 4, 14 and 4. So 4 centimeters above and 14 centimeters of the proximal section, and then take 4 biopsies for it. Okay. Then you should be able to diagnose it. I just want to make one point after we've done the approach to EOE treatment. Oh, sorry, and I've given it away. Okay. let me just go, well, you might as well just comment on it. So I'll just talk about it. So they sort of group it into, people try a PPI first, because the PPI has got anti-inflammatory kind of qualities as well. And the exclusion diet, you could try that, but it's better to actually use budesonide, and in England they use what they call the slurry. So what they do is they actually just take a vial, a nebule vial, and then they add it to honey and give it to the patient at night. But I don't think it's available in South Africa yet, this Jorveza, which is a tablet that you put on your tongue, and it sort of fizzes, and they take it morning and evening, and then it coats the whole mucosa, and they actually get a very good reaction. They respond very well to that. And if you go on to maintenance, you just take one at night. I just want to emphasize that PPI, if you really clinically or in the history you feel that it is EOE, and you do your biopsies and it's negative, what they suggest is we've got to be careful. Most of our patients, by the time they get to your endoscopy, they've all been on PPIs and still are on PPIs. So if you clinically, out of the history, feel this could be EOE, then you must stop the PPI for at least 4 to 6 weeks and repeat your biopsies. And quite often then you will get a positive eosinophilic count. How many eosinophils has it got to be? More than?
At least 15
Yes.
power field.
Okay. So what stages of EOE can one find?
I think you'd go from a spectrum of normal findings all the way to strictures when it is very severe.
Yes, but there's sort of two groups or stages of eosinophilic. It starts with one and it progresses to the other.
I'm not sure.
Okay, so it usually starts with the inflammatory process, and then if it doesn't get treated, it will go over into fibrosis, and that's when you get your you get a narrowed esophagus, and you can also get your strictures. And what would you find with the inflammatory, if you had to look at your high resolution manometry, what would you find with your inflammatory stage of EOE?
You'd probably find spasm.
Interesting enough, you can basically get any kind of finding, but specifically not spasm. You can get spasm, but with the inflammatory, if you think about it, what gets inflamed and how can it present? You present dysphagia, so what do you think you can find there?
Would your IRP be raised?
Yes, your RP. So it can present like an outflow, OGJ outflow obstruction. And then with the so you can OGJ outflow obstruction, or if it's fibrotic, then you get, because it can't expand your esophagus, you get compartmentalized pressurization, like over here. Okay. All right, so this is also just another diagnosis of EOE, how it can be managed, as I said, with PPIs and diet, and then your steroids, and then once you with each intervention, say for instance after your dilatation, if there was stenosis, you've got to rescope and biopsy every time and just see that it is still under control or been inhibited, and then you can always go on maintenance therapy, as I said, with a 1-day dosage. Okay, so, and I just think with EOE, you know, people tend to forget to ask about bolus obstruction. So if you get a young male, always remember to ask about bolus obstruction. Impaction, yeah. Okay, so this case is a 60-year-old lady with an 18-month history of dysphagia that has got progressively worse. She experiences heartburn. She gets dysphagia with each meal, regurgitation to solids with each meal, no chest pain, and she has a weight loss of more than 5 kilograms. So the gastroscopy finding was a distal esophageal diverticula. Just wanted to show you the diverticulum. Yeah, the diverticulum that you can clearly see there. And I'm not sure if this other one will play. Let me just see if I can get it to play. No, it won't. It doesn't matter. But you've got the idea of what the, oh, there it goes. Okay. So that's just to illustrate what it looks like on gastroscopy.
Sure.
This was a very large diverticle. There's one of Matt's patients.
Hmm.
Can you see the two openings?
Yeah. Yeah.
So you can clearly see the
Hmm.
two openings.
Did she have halitosis, Sassa?
This patient?
Hmm.
No, because it was a distal one, so it was
Okay,
more.
but it looks so bad.
Yes, no, but it was a very large one.
Okay.
Okay, so what types of diverticular do you find?
So
And
you
where
get
do you find them?
so traction diverticular and pulsion diverticular.
That's right. Where
Um,
do you find the traction one usually?
like to say not distal, sort of mid.
Yes. Okay, so that's mid-esophagus because you've got your Zenker's proximal and what one have you got distally?
Pulsion.
Pulsion. Okay. Okay, so we've got these two. What is usually associated with pulsion diverticular?
An OGJ outflow obstruction, malignancy,
A more broader problem that you've got to think of or exclude.
sort of malignancies,
No.
something causing increased pressure in the lumen.
No, it's associated with something.
Um,
Okay, I'll give you a clue. Why would you, if you see a pulsion diverticular, why would you send them for high resolution manometry? What are we looking for?
you're looking for achalasia.
Well, it can have achalasia, but it's actually a motility disorder. Okay, so pulsion diverticular are associated with motility disorders, any kind of motility disorders, and that's why you actually always refer that such patients for a high resolution manometry. And what causes what is one of the causes of attraction diverticular?
It would be compression, pulling forces on the outside of the esophagus, so
Yes.
potentially fibrotic lungs pulling on the
Yes, and
esophagus from the outside.
causes fibrotic lungs.
Post-TB lung disease.
That's right. So in South Africa, mostly probably TB. Okay, now remember the history of this lady. If you looked at the barium swallow, what do you expect to find with such a history, except for the diverticular? If you must I refresh you on her history.
From a history, there were a couple of red flags. She was an elderly lady. It was progressive symptoms, and she did have weight loss.
But not, so the typical red flags are actually over 50, weight loss of more than 10 kilogram, and the duration of symptoms only less than a year. So she, except for being 60, she didn't have any other red flags. So what I've told you already, so a diverticular is associated with a motility disorder. And in her case, she had dysphagia, regurgitation, chest pain, a little bit of heartburn, weight loss. What do you think, or what would you expect to find with high resolution manometry?
So on high resolution manometry, I'd expect to find an increased IRP.
And that would be associated with what condition? What
accolade?
Yeah,
Accolade.
accolades, yes. We can't really, we can't, out of the history, we can't really, except if it's been a long-standing history, we can't really say if it's type 1 or type 2 achalasia. Okay, so that one we've covered. Okay, so you can see here she had a large diverticulum and then the bird beak esophagus. And what type of achalasia is this?
Type 2.
That's right. Why do you say type 2?
Well, the IRP is raised, and it looks like there is panesophageal pressurization as well.
Okay. Yes. And okay, I'm going to make, there's something strange about this tracing. What, I'll just show you the next slide as well. What is a bit strange here?
Is that where the pressure goes, like there's a dropout almost completely? Is
Yes,
that in
yeah.
the hernia sac?
No, she hasn't got a hernia. This
I
is
mean, the
this.
diverticulum. Is that
No,
pressure?
no. I wasn't, you don't see the diverticulum unless you're inside the diverticulum. But no,
Okay.
if you look at this,
Yeah.
pressurization, and here it's what mechanism, how could you explain this happening?
I'm not sure. Or,
Okay, so there's a lot of buildup of pressure in the esophagus, and then suddenly it's cleared. So it's either the patient vomited, but why do you think she didn't vomit?
she may have passed the food down.
So what if she had vomited, then you would have seen epigastric pressurization, because she would have retched. So what this is she had a let me just quickly go on. Okay, here you can see what she had was a transit relaxation. So the lower sphincter relaxed, and then the food went through. So that you can see the pressurization was relieved. It wasn't as high as the first one I showed you. Okay, so she didn't vomit. How would you manage such a patient?
So with
type 2.
with her, you would assess whether she's a surgical candidate or not. If she is a surgical candidate, you can think of doing endoscopic therapy, which would be a achalasia balloon dilatation versus a Heller's myotomy.
Heller's myotomy. Okay, or you could do, what's the third option?
A POEM procedure.
POEM. Yes. The big thing is with type 2. I think you did read the achalasia trial. You had it in there. But what happens to the type 2s?
The type 2s over time, well, they all will recur again, but they may eventually go.
If you treat your type 2, what is
If
typical? If you treat your type 2, what is typical of your type 2?
They will progress to type 1 later down the line, or
that's if you don't treat them. Yes.
If you don't treat them. If you treat them, the symptoms probably would be relieved.
Okay, I'm probably not asking the question correctly, but the type 2, typically of type 2, it doesn't matter what treatment you offer them. They respond very well to any treatment. So balloon dilatation or Heller's or the POEM. A type 1 typically does better with surgery. And your type 3 typically does better with a POEM, because then you can see exactly, where the spasm is and how high to make your myotomy. Okay. All right, so we spoke about that. Okay, so now our third case. This is a 57-year-old gentleman, and he had changed his diet 2 years prior because he was worrying that he might develop diabetes. So he dropped quite a lot of weight. But despite losing weight, he still developed heartburn and regurgitation. And on the gastroscopy, it was the LAA and a small hernia. He was prescribed OMEs per day, and the heartburn was much improved, but not the regurgitation. So he had a high resolution manometry. And how would you describe this?
Okay, so on his high resolution manometry, his IRP is low. Well, it's not raised. It's 7.
Mhm.
But I'm not seeing much contractions.
You're seeing no contractions.
Correct. Yeah.
Mhm.
Yeah, not seeing any contractions. So
So
does
what would you call that?
ineffective esophageal motility, no, absent contractility.
Yeah, absent contractilities, and that would fall under your broader group, dysfunction
Disorders
of?
of peristalsis.
Yes, that's right. Okay. So you can see here we did the multiple rapid swallows, and there was still no contraction. And here we did the rapid drink challenge. So your multiple rapid swallows, what does that look at?
The multiple rapid swallows, I think you're trying to not miss a type 1 achalasia.
So what does the multiple rapid swallows look at?
Contraction reserve.
Yes, peristaltic reserve. And your rapid drink challenge, what does that look like? What does that look for, or excludes, or?
Would that not reserve? We've done
No.
that already. We're trying to exclude OTJ outflow obstructions.
Yes, so you want to, because with the rapid drink challenge, your LOS relaxation should be ongoing, so it should relax totally because of the NO that occurs. And that if there was any increased IRP, you would see pressurizations on your manometry. Okay, so why is it not achalasia type 1?
The IRP wasn't raised, even with the provocative tests.
Yes, it was 7, and your provocative testing was negative as well. Can one get your achalasia with normal IRP?
I'm gonna say yes.
Because I've asked it in such a way. Yes, you can.
Yes.
Why is this not achalasia?
Even this,
the IRP to be if this was a normal IRP achalasia.
you'd expect that the IRP would have raised with your provocative tests.
With the test as well, but usually with your 10 swallows, the IRP is at the upper end of normal. You won't find a achalasia with an IRP of 7 or 6. You did answer it correctly. You would have seen it with the provocative testing as well. What systemic illness must one exclude if you find hypotensive LOS and absent contractility?
Systemic sclerosis.
That's right. So you must always do a connective tissue screening test when you do find something like that. Okay, you must remember you can get a low IRP if it's a treated type 1. So you must always in the history just make sure that she wasn't a treated achalasia at any stage. Okay. And how would you treat such a patient?
Absent contractility, pharmacologically, you can offer the patient the PPIs. I mean, there is evidence of reflux there. And then also non-pharmacological treatment, guidance on how to eat meals, positioning of when going to sleep, things like that.
Yeah, so you'll definitely give PPI because they will reflux. And then the broader term is you're going to treat it conservatively. Okay, so it's conservative treatment, and you would treat aggressively with PPIs, quite often a double dose of PPI, because you don't want them to get strictures. Why not a fundoplication?
There's no contraction reserve there.
Yes, so no peristaltic reserve. So you would be worried if you do, even if you do a partial wrap, that it would lead to dysphagia post fundoplication. Okay. Okay, so we've actually asked, but you can just re-emphasize, what do we look at high resolution manometry to just assess the peristaltic reserve? It is the provocative testing, but what tests can we use? You've said multiple rapid swallows.
Well, and the multiple rapid swallows and the rapid drink challenge.
Yes, there's another one.
Position change? No.
No, it does go with position change, but what is the next provocative test that I can do?
I'm not sure.
Solid swallows. So you give
Consoles.
them bread, 1 centimeter by 1 centimeter, and let them eat, and then you look for clearance contraction to see if there's any reserve. Do you know what the dysphagia score is?
That's not the ECOT score, eh?
No.
No, then I don't know.
Okay. So the dysphagia score is just to see what, if you can predict if someone can develop late oncomer dysphagia post fundoplication. So if you do your 10 water swallows and you do your multiple rapid swallows, if the DCI, if the strength of your contraction of the multiple rapid swallows is more than your mean or your average of your 10 water swallows, then that shows that there is peristaltic reserve. But if you take your multiple rapid swallows DCI over your mean DCI of the 10 swallows, that equation should be more than 1. If it's less than 1, they tend to get late oncomer dysphagia post fundoplication. So it's a nice kind of score to use when a surgeon has referred the patient to you, to actually not recommend them to do a fundoplication. Okay, so our last case is why I'm putting the history like this. People can give you the weirdest histories, and it can actually take you, off track. So this was a 22-year-old male, developed regurgitation when eating fruit, sort of at the end of 2022. Became progressively worse, and he experiences regurgitation with each meal, and in between meals he vomits foamy mucus that's not acidic. He burps when he eats, occasional chest pain, slight dysphagia per occasion, and weight loss about 4 kilograms, no heartburn, and no other comorbidities. On the history alone, what do you think this could be?
It could be a mechanical cause. He is vomiting.
He didn't have heartburn. So in a young man,
okay.
you probably have
That
thought
should-
GERD,
yeah.
because GERD can really give you dysphagia.
Yeah, good can give it. He's not complaining. He's vomiting foamy mucus, but it's not acidic. So I think potentially a motility disorder. One of the achalasias.
Yes, that's right. And what else? But if you look at the age, and he's male.
He's young. EOE maybe with his age.
So it's EOE as well, huh?
Yeah.
Okay. Okay, so you've just got to think of EOE and achalasia. Okay, now we've got a pretty picture. What is that?
So his IRP is raised. It's 52. So be going sort of down the disorders of OGJ outflow. And I think he probably has type 2 achalasia.
Okay, this type 2 achalasia. There you can see it again. Why do you say it's type 2?
So there looked like there was panosophageal pressurization as well. Was then
So there was, what are the two things that you must see with type 2 achalasia? What must you see?
100% failed peristalsis,
That's right.
and then at least more than or equal to 20% with panosophageal
Okay,
pressurization.
that's right. Yeah, that's so the increased IRP and more than 20% of panosophageal pressurizations. I think in your exams, I think this achalasia, they did ask it in the last paper, but I think that's the condition that most people will probably ask you about. So what's the definition of PEP?
Panosophageal pressurization. I would think uniform pressurization of your esophagus throughout.
Okay, but specifically from where to where?
From the upper esophageal sphincter to the OGJ.
That's right. So, and then they uniformal, you know, you could see it
Yeah.
very clearly on that manometry tracing. So it stretches from the UES down to the LOS upper border. Okay, so case 4 was 69-year-old lady with typical GERD symptoms. What are the typical GERD symptoms?
Reflux.
Yeah, regurgitation, reflux,
And
yeah.
then other symptoms around it may be
Typical. I'm asking for typical. There are 3. I'll give you a clue. There are 3.
Dysphagia,
Uh-uh.
non-cardiac chest pain,
That's extra esophageal.
the reflux after meals, reflux at night, coughing.
That's reflux covers all of that, or regurgitation covers all of that. So very typical. What do the patients come and tell you? I've got
Seer.
heartburn.
Heartburn.
So the typical GERD symptoms is heartburn, regurgitation. Sorry, as you did say, they've now added atypical chest pain or non-cardiac chest pain to the symptoms of typical GERD. Okay, so this lady's gastroscopy findings was normal except for a hiatus hernia, and the barium swallow confirmed the hiatus hernia. With above findings, what would you expect to find with high-resolution manometry? So my question is actually, what is associated with GERD when you look at a high-resolution manometry? It doesn't equalize it, but it is associated. There are 3 findings that you can see on high-resolution manometry in a typical GERD patient.
Is there a dropout of pressure at some point above sort of the upper esophageal sphincter? Then I'm not sure.
Why do we reflux? When we reflux, we all reflux normally, but why will one have symptoms more than the other one?
The anti-reflux mechanisms are compromised.
That's right. Okay. What are they?
Your accruder of your diaphragm,
Yes.
your mucosa itself, and your esophagus itself.
So your barrier is basically your lower esophageal sphincter. That's the internal one, and the external one is your diaphragm. You've got a hiatus hernia that affects your barrier. And then your motility must be normal, because you need a peristaltic contraction to actually clear your acidic reflux if you know, if you do reflux. Okay, so if I ask you the question again, what would you be looking for when you look at your high resolution manometry in a patient with GERD? You would look for?
You'd be looking for peristaltic changes.
Or a better word?
The failure of contractions.
Disorders, no? So absent
Disorders, yeah.
contractility of or ineffective esophageal motility, and what would you be looking for with a sphincter?
The IRP would be low.
Yes, the
Yeah.
RP would be low, but the LOS pressure, what would that be?
Low esophageal sphincter would be decreased.
Yes, low. So you get hypotensive LOS, and then typically associated with reflux disease is also the presence of a hiatus hernia. Okay.
Yeah.
So now, so this is you look for a low LOSP, hernia, and IEM. That's associated with GERD symptoms. Okay, so here we've got, so what can you tell me about this tracing?
Let me have a look. So the RP is very low. It's 1. So
Yeah, that's fine.
There's almost no peristalsis. It starts with high and drops off.
What do you look at to evaluate your peristalsis? What metric?
Is that the DCI and
That's right. So the DCI is basically the force of what your peristaltic contraction is measured by. And 124, what would that make it?
that would make it abnormal. It's supposed to be less than 100.
No.
Between 100 and if it's between 100 and 450,
then it's
that
called
is ineffective esophageal motility.
Okay, or the other word?
Absent.
No, it's not absent. Absent is below 100. So in between.
Ineffective.
No, ineffective, but it's a weak contraction that implies ineffective motility. Okay, and above 450 is normal. Okay, what else can you see here? If you follow peristaltic contraction.
There is a pressurization below the lower esophageal sphincter over here.
So what do you think that is?
Is that the hiatus hernia?
Right. So in other words, what do you think this is? Here you can see she took a breath and it lowered. The pressure changes. So what is that? That's
your bolus moving along.
No, the bolus will be here, but this is your contraction. Oops.
Okay.
That's no, previous. Let me just go back. Okay, so what would this be? So here's your peristaltic contraction, and what would this be?
Is that the opening of that hiatus hernia?
No, that is your this is so okay. Let's start here. So here you swallow, and then what happens here? As soon as you swallow, what should happen to the lower esophageal sphincter?
It should relax.
That's right. And after a relaxation, you always get a contraction. So what is that?
The contraction after relaxation. I'm not sure.
That's right. Yes, it's the contraction after relaxation, after the peristaltic contraction. Can you see down there? And then it relaxes, and then your LOS contracts, and then it goes back to normal, which is, in this case, was a very hypotensive LOS. Okay, so what do you think this is? This pressure bar down here.
Is that pressure bar the hiatus hernia?
Not the hiatus hernia?
The
pressure
lowest.
The external of your reflux barrier. We said it's the LOS, is internal. What's your external barrier?
Crural diaphragm.
That's right, the diaphragm. So that's the diaphragm. Okay, so this whole area is your hiatus hernia. So the area above your diaphragm. So if you measure, you'll measure from here to measure your the size of your hiatus hernia. Okay.
Okay.
Right. In this case, so this is a lady that's been referred with GERD. What else would be very important to perform during your high resolution manometry in this case, and why?
Would you want to, what was that, the score? Would you want to check for pH and impedance as well?
You can do that later on, but we're still just busy with the manometry.
Contraction reserve?
That's right.
Reserve.
That's right. So because if this patient needs to be referred to a surgeon, it's important that you know if there's peristaltic reserve or not. Okay, so what did I do here? What procedure, provocative test did I do here? I've actually told you.
Modified rapid swallows.
Multiple rapid swallows. Okay. In the multiple rapid swallows, you just give 2 mils, 10 mils, but 2 mils at a time at quite a fast speed. And then you expect the LOS to relax. And then you're hoping to get a good clearance contraction. But in her case, it was even though you see a little bit, but it was less than 100. So she's got poor peristaltic reserve on the multiple rapid swallow. Okay, we've covered that. What other provocative procedures could help with assessing the peristaltic reserve? It was the multiple rapid swallows and
the rapid drink challenge.
Yes, the rapid drink challenge, and the third
then
one?
a solid.
That's right, the solid swallow.
Solid swallow.
Yeah, so that's where with the new Chicago, we do Chicago version 4. So your primary position, you can choose your one if you want to start upright or supine. So the primary position that we use is supine. So you do 10 wet swallows in the supine position, and then you do the multiple rapid swallows also in the supine position. But then you put them in an upright position to perform the rapid drink challenge and the solid swallows. That's then part of your Chicago 2.
Sassa, sorry to butt in there. How many slides is your case 5? Because
no, I think we can stop here because I'll rather show what's the time now?
Basically 7 o'clock.
Oh, okay. Maybe I can. What I just wanted to cover is just that the Eckert score. If you can just explain to me what the Eckert score is and how do we use it? That's all actually in achalasia.
So the Eckert score you use you can use it in patients with achalasia to assess, to sort of when you're following them up post-procedure to see if they've gotten better or worse, sort of as a reproducible thing. There's 4 components to it: dysphagia, chest pain, regurgitation, and weight loss. And then you can sort of see whether your treatment was effective or if it's worsening over time.
Yeah, so when you take your first history, you've got to look at those 4, and according to if it's occasionally, if it's every day, or if it's with every meal, you score it out of 1 to 3. And if your Eckert score is more than 3, then that points to achalasia. And if you've performed the Hill's myotomy or pneumatic dilatation, it's a very nice way to assess follow-up and if your treatment was successful, because you would want it the Eckert score to be below 3. Otherwise, they will become symptomatic again. Okay, I think I've tried to cover sort of some of the important facts, and then we're done.
Thank you so much. That was fantastic. I think it was a different approach to how we've done this. And I think by showing cases and then just highlighting sort of nuances and salient points that you can't get from a textbook or from a review article has been very, very useful. I always learn something new with these sessions. This is such a complicated area. And I learn every single time. Aslam,
Yes, Prof.
were you coughing because it got quite hot in the hot seat? I think you did
I
very well.
I was coughing. I think I should stick to doing long presentations.
I think you did very well answering the questions under pressure. So well done, and thank you for that. I really appreciate it. I wonder if anybody has any burning questions for Sassa. Please feel free to post them on the
You
chat.
can mail me as well. I don't mind.
Yeah. Or if there's anything hot that you want to discuss now, you can unmute and let us know the question. Looks like, Sassa, you blew them away with your cases.
Well, I hope I haven't lost them.
No, I don't think you have. But as Sassa says, if you have any questions, she's quite happy to take them. If you don't know her email address, you can email them to me or to Karen. We'll be sure to pass them on. So thank you so much, Aslam. And thank you, Sassa, for your expertise. As I say, we're going to be very, very lost without you. I'll have to call you back from retirement. We're not quite done with you yet. And I just want to remind you all that this topic is so important. It comes up probably in every exam, either in the written or the oral, it shows up. And I think you have to understand it because these disorders are really, really difficult. And as Sassa nicely showed, you have to take a proper history. You have to take the time to understand that you and the patient are actually on the same page in reference to their symptoms, because patients say all sorts of things which may not mean the same thing. And you don't want to put a patient under needless investigations. VG, I've noted your hand. I will come to you. So this is really important, and it's the most frustrating area for patients. They've seen multiple physicians, including gastroenterologists, who really cannot help them with these symptoms, which affect their ability to enjoy food, their ability just to eat, and to socialize, because, eating is such a social thing. So it's really important that you understand this area. So if you want to learn more, 2 years ago, in January 2022, Sassa did a similar session, but it was a slightly different approach. So you do have access to that video and that recording. It's on the Gastro Foundation website. It's session 2 in 2022. So I think there she also goes over manometric findings and blah, blah. So if you want to go back to review this, I think that could be a good place to start as well. And then obviously you can revisit this particular recording today. Okay, VG, speak to us.
Hi, Mashek. I'm sorry, I think we're a little bit over. But since I have the expertise on your line here, I thought I have to ask. One thing, Sassa, volume reflux. I know it's a little bit away from this age here, but you hear this term from both physicians and lots of surgeons that this patient's got volume reflux. Now, we all sort of have a qualitative idea about it. Is there any specific way we can say, yes, this is volume, so-called volume reflux? Can we accurately quantify that? And what percentage of people with reflux disease have a peristalsis? Last time I checked years ago, it was estimated that up to 5% of people with reflux would have a peristalsis secondary to the reflux. So it's just one of those things where long-standing reflux can cause people to develop peristalsis, and in a proportion of them, they will normalize with acid suppressant treatment.
Yeah, so volume reflux, in other words, it's basically reflux that comes up into your mouth. So the best way actually is your history, and then also if you do pH impedance, and if you get full column reflux episodes, those if you've got a lot of them, the incidence of volume reflux is higher because you measure up to 17 centimeters your reflux episode. And then the other question was your second. The peristalsis. Oh, okay. That's where,
secondary
yes,
to reflux.
yes.
Yeah.
So that's where the new Chicago 4, if you put your patient in the upright position and give them solid swallows and a meal, quite often you will elicit peristalsis. That if you just give them water would probably look like a peristalsis. So that's why it's very important for you to actually do the supine and upright positions and to give solid swallows. I haven't got the percentage of what percentage of reflux people get absent contractility, but that's mostly reflux people get IEM, ineffective esophageal motility. It's a much smaller percentage that will get aperistalsis.
Okay,
and probably was overdiagnosed because we were all using just water swallows in the supine position.
Yeah.
Yeah, thanks. I'm still a bit concerned about the volume reflux, which is sometimes I see as a sort of term that's just thrown around, and it can be a bit subjective because, I occasionally have what I would call a bit of a volume reflux, but I ain't on any proton pump inhibitors or anything. But yeah, that's interesting to.
But if you do your impedance pH, to say you've got reflux, if you use your Leon classification, you've got to have more than 80 reflux episodes.
Yeah, sure. I agree.
All righty then. I think we're going to stop it there. Thanks, VG. So thank you once again, Aslam, and our lovely Sassa Botha. And thank you so much to ECHO, University of New Mexico, and the Gastro Foundation. Karen, thank you so much for organizing us, keeping us organized. As I said, the recordings are all available on the Gastro Foundation, going as far back as the very first webinar that we did. And just to remind you that in 2 weeks' time, we're doing another important topic. So approach to dyspepsia, including functional and uninvestigated dyspepsia. Another huge topic. Julian Gaskin is going to present that one. So thank you so much, everyone. Really appreciate it, and have a fantastic evening. Goodbye.